extensive experience in writing, research publications, and book chapters. Dr. Larry has worked as a scientific researcher in the United States Army Research Institute of Environmental Medicine. Having started as an international undergraduate student, Dr. Larry obtained his MD and PhD degrees from Johns Hopkins University School of Medicine and completed his MBA from University of Kansas. I request Dr. Larry to address this event to give us his valuable inputs to all of us who are aspiring to be like him. Welcome, Doctor.
I'm sorry, sir. Yeah, thank you so much.
Thank you. You make me sound bigger than I am. I do appreciate the kindness. I'm very privileged to be here with you, and I look forward to seeing the presentations that you have to give today.
Thank you, Dr. Larry, for your great work. So I would now like to introduce Dr. Varsha Bhashyakarla. Dr. Varsha is a graduate research assistant at the Gate Institute of Population and Reproductive Health, Johns Hopkins University. Her work is focused on implementing the family planning programs in the developing countries, and she has also conducted research on COVID-19. So she obtained her master's in public health from Bloomberg School of Public Health, Johns Hopkins University. And being an international medical graduate, she also worked as a primary care physician in India for a few years. So I request Dr. Varsha to share with us her words of wisdom. Welcome, Doctor.
Thank you for the introduction, Anjali. It's really a great honor to be here. I'm looking forward to hearing the post presentations, and you guys are the future of healthcare, so it'll be great to hear what you have to say. Thanks for having me.
Thank you, Doctor. So I would also like to introduce Dr. Vikas Bansal. So Dr. Vikas is a research associate at Mayo Clinic and has conducted studies on the relationship between metabolic syndrome and COVID-19. Some of his research are also focused on critical care and pulmonology, and he has also held an academic position of an assistant professor of medicine, and he has worked as a program director at the Institute of Liver and Biliary Sciences, Delhi. As a medical graduate from India, he has also worked as a senior research officer of public health with the state government. And I request Dr. Vikas to address this event by sharing his valuable thoughts. Welcome, Doctor.
Thank you, Anjali, for nice introduction. I am not so big, as you, Dr. Sona also mentioned. We are not so big. We are just helping each other. And I am very honored that I am the part of this event. Thank you.
Thank you, Dr. Vikas. So finally, I now move on to Dr. Ilham Saidi. Dr. Ilham is the National Project Head of ISCI's Peer Research Mentorship Program. So he is a public health professional specializing in infectious disease and health equity. He is working as a program officer at PATH, Uttar Pradesh, and as a regional manager at the United Nations Development Program in Chennai. So he also worked with the George Institute of Global Health, Australia, Tata Trust, Maharashtra, National TB Elimination Program, and WHO. I request Dr. Ilham to share his words with us. Welcome, Doctor.
Anjali, I think we can ask Dr. Ilham to speak towards the end. I think there must be some problem with his connection.
Okay, yeah. So moving on. We are moving on to the core part of this event, which is the poster presentation. So before beginning the event, I would like to give a brief outlook of how the presentation is going to be. So each participant will be given 3 minutes for the presentation, and followed by there will be a question answer session with the judges. And finally, the audience who are watching us live on YouTube will be given time to bring up their questions. And there will also be a warning bell at 2 minutes and 45 seconds, and also at 3 minutes when the allotted time is over for each participant. With that being said, I'm inviting our first presenter of the event, Dr. Stephen Alexander.
Yeah, can uh, am I visible? I think,
Yes, you are.
yes. Can I start?
Yeah.
Yeah.
Go ahead. Yeah.
Good evening, guys. My name is Dr. Stephen Alexander. I'm a graduate from Andhra Pradesh, which is a rural place of Andhra Pradesh state, in India. So my introduction is I'm working as a medical officer in one of the rural places in Andhra Pradesh state, which is from India. So the topic which I chose is community knowledge, attitude, and practices towards tuberculosis in India. That too, I selected a cross-sectional study. I took a study of nearly 500 people, knowledge and their attitude towards uh, tuberculosis. So my main abstract is, as you all know, TB has been there from many years, and we know that it is a curable disease. We were treating it since 1947. But more than 1.8 million tuberculosis cases are still present in India. Due to COVID, there were so many underlying causes which we couldn't treat because of the lockdowns, because of the unavailability of transport. So many problems were there. TB patient could not reach to the hospitals to take their regular medications. So, on occasion of this, I took this concept to do a study. I took a 500 random people. I talked with 500 random people in near to my place, and out of which
Dr. Stephen, we are not able to hear you.
Hello, Dr. Stephen.
Okay, so his network was unstable.
Yeah, I think so.
Okay.
Shall
We can wait for 5 to 10 seconds. Let's wait for this.
can you see me?
Dr. Stephen, you can stop your video because I think that's causing a problem with your audio. So you can just, yeah.
Yes.
Okay, sure.
Yeah. Is it okay now?
Yeah, works.
Yeah. So I did a cross-sectional study of 500 people. I went and talked to them individually with the help of one of my colleagues, and we found out that out of 500 people, 4.8% were affected with tuberculosis, and only 10% knew that it is caused by bacteria. So I'm talking about a population which are very far from the cities, rural population, uneducated, and so on. So only 10% knew that it is caused by bacteria, and the it is surprising to know that most of the people don't know that it is spread from one person to another person. I can say that nearly 35.6% only knew that it is spread from one person to another person. What is more surprising is that people don't know that government is facilitating with the treatment for tuberculosis, and they said that if we come to know that government is giving us treatment, we would have gone there to take the treatment. So that is really surprising because of the all the digital media which we have in these days. Even still, we are unable to reach to the local population, and nearly 79% people they doesn't know that if the treatment is discontinued, there is a chance that it can become into multi-drug resistant tuberculosis, and mostly 12.5% of the people they rarely take the treatment for more than 3 months. So this is the ground reality. We have dot providers, we have workers who are helping the tuberculosis patients to take the treatment, but that is all in the that is not in the ground reality. If we go and talk to a rural population, we can only see that only few people are working, only few dot providers are working to their full potential, and they are contributing to the government. But still, lack of awareness, lack of knowledge, and the attitude towards the tuberculosis. They think that it is nothing, it's just like a common cold and cough. And the practices, these are all hindering the eradication of tuberculosis. So with this data, I can say that the people of Ongole, I mean, the place which I work, which I did this cross-sectional study, they have less awareness about the cause and spread of tuberculosis. Despite government's best efforts to increase the diagnostic tools, to provide treatment, to provide incentives in the form of money, even still, government is doing so many things, but there is a clear gap between the government works and the population, that is lack of knowledge. And the attitude of the patients towards treatment, a long-term treatment of 6 months, it has bring up an attitude of a resistance, so that they don't want to take the treatment for 6 months. They wanted an immediate remedies to cure the disease as early as possible. That is one of the main cause for tuberculosis not being eradicated till now. And the practices are not going for regular treatment, not going for regular checkups, not being available to the government officials when they come. So on and so forth. There are so many problems in the community where dot providers even can't find out the patients, and they cannot convey them also to take the medications. So with this, I can say that we can break the chain if we can break the chain if we can educate the population, if we can go to the grassroots of this rural population to bring up the community knowledge in the form of a small pictorials, or in the form of arts, in the form of posters or something like that, so that we can bring out a change in their attitude to take the medication, to go to the hospitals to take the treatment, so that it can increase this can mobilize the patients towards the hospitals. And there is a social stigma of being thrown away from the normal population.
May I ask a question, Dr. Alexander, or?
Sure, sir. I may request.
Did we lose you? Did we lose your?
Yeah, I think there is. I think he will. We've lost him. I think. Yeah.
Okay.
Yeah.
He's back.
Yeah. Can I continue?
Yes, please continue.
Hello.
Yeah, we were unable to hear you.
Yeah, I reached to my conclusions. So the social stigma of not being seen as a patient for taking long-term treatment, this is more prevalent in the community. So what I mean is that if you can do something to educate the people, to increase their knowledge, to change their attitude, this can help in eradicating the tuberculosis from the grassroots level, rural population. To my surprise, even the educated people, like I came across some student who is a graduate, but still presented to us with blood vomitings because of tuberculosis. The picture is that he doesn't want to take treatment, and he doesn't know what will happen if he don't take the treatment. So the knowledge and attitude is very lacking in the community. If we can increase this, we can eradicate the tuberculosis in the next few years. So with this, I want to conclude my presentation.
Thank you, Dr. Stephen. I now request the judges may ask questions to the presenter.
Yes, Dr. Alexander, this was an excellent piece of work. Thank you very much for your presentation. I have a couple of questions. In your program, are you using directly observed therapy for anti-tuberculous medication administration?
Yeah, can you please repeat which therapy did you mean?
Are you using directly observed therapy in your program?
Yeah, the government is providing a program to give the therapy known as dot providers. So they will directly observe the patient taking the tablets, but the ground reality is these dot providers are taking the salaries from the government, but they are not going to the patient to see whether they are taking the tablets or not. So
Interesting.
in the community, the dot providers are not really visualizing whether the patient are taking the treatment or not. So there is a lag.
I see. Because it would seem to me that's also an excellent vehicle for providing education, not just medication.
Yes, yes, yes.
How would you propose to remedy this gap?
Yeah, I would say, apart from one individual going to the hometown, going to the places of the TB affected people, it should be from a community of doctors, from a community of health workers, giving them knowledge, undivided knowledge. Like you can provide posters everywhere, so that whenever they go through the causes and treatments and effects of the tuberculosis, they will have their self-realization that if I don't take a treatment for it, it would kill me. This sort of perception should come into the patients, that a single dot provider cannot give it to the patient. It should be from different sources, using multimedia, using newspapers, using social media, using small cultural activities. These all should directly implement on the patient. Then only we can provide, we can improve the knowledge and attitude of the patients towards the tuberculosis.
It sounds like what we would call a marketing problem in business school.
Yeah.
Excellent. Thank you.
Thank you.
Dr. Alexander, I would like to ask you one thing. As I see that you
Yes.
conducted this survey in village, so I assume that all these 500 people are uneducated, right? Or there
No,
is
sir.
some education
No, sir.
level there.
No, sir. I would like to add. So this survey was conducted in 2 to 3 regions. One is in a semi-urban population, and I conducted this survey by taking consideration of 3 rural primary health centers which are close to my city. So this include educated people as well as uneducated people, such as farmers and all. And I quoted an example of an MBA student who is a graduate. He also comes into this category only. So it
Okay.
is a mixed survey of both educated and uneducated people.
So we are not able to see the distribution here, like, because is there any comparison, like what is the knowledge, attitude, practice in uneducated and what is the KAP percentage in educated people? So because what I understand that if we go for like presentation and everything, so approach for educated person will be different than uneducated. Like uneducated, they will not understand by the reading the posters and newspaper and everything. So if we will do some like of theoretical what we call is a street drama or something like that in the local language, so they can, it's like nukkad natak, if you know about that term, so they can educate, right? How much
Yes.
you think? So if you can,
Yeah. So what
did
I
you see
thought
that?
was,
Yeah.
what I thought was, if I take a rural population, it would be a very, I cannot justify the knowledge attitude with them when compared to other people. So I thought I will mix all the people and see a gross idea, what is the knowledge in the whole community. So I mixed educated, uneducated, and some students, I mixed them. So that is what it came out as a mixture, rather than taking only low educated people.
No, but that strategy to prevent, to eradicate the TB also change according to their education level and socioeconomic status. Am I right?
Yes, yes.
So if I would like to see that distribution in the next time, whenever it is there, or maybe in the publication when you publish this paper.
Okay.
And it's a very good, strong work, and I appreciate your hard work on this.
Thank you, sir.
Hi, Dr. Alexander. Thank you for your presentation. I think it was interesting that you did some primary research here to get to a deeper understanding of what's going on in the community. My question to you is, you've considered rural population here, but if your study population was more of the urban kind, do you think you would see a different result? Like your results section, do you think you would see different findings there?
No, ma'am. What I meant to say was, even in the rural population or in the urban population, the knowledge of tuberculosis, take even a graduate, he also doesn't have a clear knowledge of tuberculosis. So there is a gap of knowledge. That is the gap that changed the attitude towards the treatment. So if we can educate the rural population, leave them whether they can understand, whether they can whether they can't understand, the way you provide them the knowledge, that doesn't matter. The attitude of the patient towards taking treatment is what mattering. We are providing so many facilities. We are providing diagnostic tools. We are providing treatment. We are paying them money also to take the treatment. But the basic attitude of the patients, whether they are educated or uneducated, also the basic attitude is wrong. They are not even willing to take the treatment.
So, what I'm understanding from your answer is your study population did have a mix of rural and urban individuals?
Yes, yes.
Because, I just trying to make the distinction, like educated versus educated is okay, but were these educated and uneducated individuals a part of a rural population, or was your population a mix of both? It was a mix of
Yes,
both,
yes.
correct?
It was a
Okay,
mix
great.
of
Thank
both.
you. Got it.
Hello, Dr. Alexander.
Hello, sir.
Am I audible? Thank you. So I would like to first comment that DOS provider, like you said, they are not employees. They are actually volunteers. They don't get any salary from the government to reach out to the patient to get them their medicines administered.
Sir, I would like to correct this point. I'm staying in a rural Andhra Pradesh, and my father works as a my father works as one of the employee in the primary health center. So in that center, they volunteer them. They give incentives to the ASHA workers to work as a dot providers. I have seen the reality, sir. I mean, it might vary from
These
different
are,
states, but I don't know.
I agree with you, but these are incentives. They cannot be considered as salary. They are paid
Yes,
to cover the
incentives.
expenses that they spend in reaching out to the patient. They're not salaries in any form, and that's why in
Yes,
India
yes.
we don't call dots employees. We call them dots volunteers, dot providers.
Yes, yes.
And
Dot
secondly,
providers. Incentives.
I would like to discuss with on the generalizability of your study, or if you would like to comment on other limitations or biases in your study.
Yes, sir. Yes, sir.
I'm sorry, I'm not able to hear you.
Yes, sir. Yes, sir. Please ask me.
Uh, do you want to comment on the generalizability of your study?
Yes, sir.
How much you can generalize it?
Yeah, what I meant was if you take a sample of people, whether that should include the educated as well as uneducated people, because a population TB cannot come only for educated and uneducated separately. It spreads from everywhere. So an educated people, if they can use mask, that can reduce the transmissibility. So an uneducated people. So the transmission does not need the level of education. So that's what the attitude comes into play. If a tuberculosis affected patient, if he thinks that he should definitely wear a mask so that he don't spread the TB to other person, then the transmissibility will decrease. So that's what the basic attitude should change, whether they leave alone their education levels.
Okay, no, like not going into much details. I was discussing the research part. Now I have some more like comments on it. Less, not exactly question. But do you consider tuberculosis a poor man's disease? Education of educated people and uneducated people is a separate issue. Do you consider TB is a poor man's disease?
Yes, sir.
Okay. Why is that so? Why do you think it is a poor man's disease? If education
So
doesn't
lack
have
of
much role to play.
so the effect of tuberculosis can be based on their socio-economic status living, as well as their immunity levels, as well as their standard of living. These are also, they will also come to play when TB is affected.
Okay, thank you very much. But I must congratulate you. Very well done on the presentation and your study. And like other aspects, I think we'll discuss it sometime. Not here. Like we have time limitation.
Yes.
That's it from my side. Thank you very much.
Thank you, sir.
Yeah, Dr. Alexander, I would like to echo that enthusiasm for your work. This is not easy to get. Data from rural locations in India don't come around every day. I think what you're hearing is a fair amount of enthusiasm from the judges for your work. And I think any number of us would be saying, we hope you can do more of it and get some more granular information about things like educational status, socioeconomic status, rural versus urban, because that's the type of information that becomes actionable after a certain point when you're trying to target populations or markets selectively for messages in education. So you are to be congratulated for this important contribution to the effort, and I hope to see you continue your efforts. I look forward to reading more about you in the literature.
Thank you, sir. Thank you very much.
Thank you, judges. As the question and answer session between judges and the presenter is over, the audience may now ask questions to the presenter. Over to Maliha for the audience question.
Hello, Dr. Stephen. Mr.
Hello.
Tom has a question for you. He is asking, what sampling method did you use for the selection of samples?
Can't hear you, ma'am.
He is asking what sampling method did you use for selection of samples?
Random samples. Those are random sampling.
Random sampling. Okay. And he has also another question. What cultural screenings were used for the data of 10% bacterial causes of TB?
Yeah, we have the network of medical officers around our place. They used to conduct regular programs. I mean, who are affected with tuberculosis, and they have a data with them. So we took the data from 3 to 4 network medical officers, as well as the nodal officer of our district. So from all the 3 resources, I gathered sample, and I took the outcome of this.
Okay, that's all from the audience.
Okay, thank you.
So I assume that ends the question and answer session with Dr. Stephen. Thank you, Dr. Stephen. Now I'm inviting the second presenter for our event, Ms. Sakshi Vatarkar.
Good evening. Can you hear me?
Yes, you're audible.
Okay, thank you. So can I start?
Yes.
Yeah.
Okay. So my name is Sakshi Vatarkar, and I'm a 5th year medicine and surgery student in Italy. I'm originally from India. And first of all, I'd like to thank the ISCI community to have given me this chance to present my poster today. My poster basically is, it talks about myths and facts about tuberculosis. As we know, tuberculosis is a very prevalent disease all over the world. And it is known that around 1% of the whole population gets infected with TB every year. And the cause of TB is a bacterium called Mycobacterium tuberculosis, as we know. So basically, the poster talks firstly about types of TB. So it is believed by some people that there can be only one type of TB. So when we think of TB, we actually get this image of a person coughing and maybe like has a fever or something. But it should be noted that there can be 2 types of TB, which can be either pulmonary TB, which is like the standardized, maybe like how we call it, but there can also be extrapulmonary pulmonary tuberculosis, which can be a systemic disease and it can affect other body organs as well. And TB is not limited to just people in the rural areas or areas of like which have less hygiene, like compromised hygiene standards, but it can affect anyone and everyone. It is very prevalent and also in the urban populations. The next point is that many people believe that tuberculosis is caused by smoking or like only by smoking, but that is surely not the case, because the main cause of tuberculosis is basically breathing of infectious air, which contains the infected particles from a person who has the infection, the M. tuberculosis infection. But also smoking can be an additional risk factor in tuberculosis, because as we know, smoking causes a compromised immune system, which can just prove to be an additional factor for the infection. And also TB is not related to genetic code, because it is an infectious disease. You catch the infection from air from a person. So it doesn't really mean that if your mother or your father has had TB, you will definitely have it. That's not the case. It is not inherited. Symptoms of TB, when we say symptoms, we can always imagine like a cough or a high temperature or fever. But even though these symptoms are very commonly seen, TB not necessarily always presents with symptoms, because sometimes if your immune system is working well enough, the infection is masked. So symptoms of TB basically appear in later stages, most probably. And TB is spread through handshakes is also something that is more believed, but as I said, it is an airborne infection. But if you like shake hands with a person who is like touched his nose or maybe mouth, and then you touch your nose, mouth, then it can be like the infection can spread. Treatment of TB is very rigorous. It can last from around 6 to 9 months, and it is also believed that a person cured of TB can never have it again. But if the treatment is interrupted in between, then maybe like there can be a recurrence of TB. And with this, I think I'd like to conclude my presentation, and I'll be open to questions from the judges and the audience. Thank you.
Yes, Sakshi. Now the judges may please ask questions to the presenter.
Doctor, thank you very much for your presentation. A very nice, very succinct summary of some of the problems that are faced in terms of patient knowledge of TB. Given these findings, what would you suggest as a remedy to the knowledge gap?
Right. So basically, the problem here is lack of knowledge, and I think, like, of course, because the technology is taking over the human mind nowadays. So information is really available anywhere and everywhere, and sometimes you can't just trust the source you're getting your information from. So first thing that like educated people specifically can do is, like, whenever they read about something, it should be important that they check their sources and how authentic they are. And of course, we can conduct a few TB awareness programs in schools and colleges in urban cities. Yeah. As for the rural areas, maybe like posters like this can help, of course, in the local language, I would suggest. But for people who can't really read, I think the healthcare workers, they play a very crucial role in actually verbally educating the people, telling them a few facts about tuberculosis, how it is curable, and how it can also be prevented by maintaining, for example, good hygiene. And if you're infected, then you can probably wear a mask or something. And even like in rural and urban areas both, I think street plays or just like events like that, which are really very easy sources to reach out to the public, can help. So maybe like setting up a skit of say 5 minutes to the max can also help people getting the facts right about tuberculosis.
Could you, for someone who has spent all of his time professionally in the Western Hemisphere, could you tell me what you mean by street plays?
Yeah, street plays. So basically, even if I've spent a lot of time here in Europe, but I'm basically from India. So street plays are basically when a group of people actually go and perform a short drama or a street play with the help of posters or maybe some songs or such like any kind of artwork to reach out to the people. So they actually get on the ground and perform some plays and talk to the people about whatever like topic is. So like here we will talk about tuberculosis, and maybe we can set up banners or something all around the city which can help people get some knowledge about this. And this could also be a help of help in rural areas, because talking to the people in their own language always helps. So even if someone who's not well educated and who doesn't really know how to read a poster can always get some information through the street plays or something.
Is this a common tool in rural India for healthcare education, street plays?
Well, not really, but not for healthcare education, definitely not. But I think like I've seen a few street plays about other topics, for example, like women's safety or topics like that in general. But which is why I think implementing this tool in healthcare, in public health, would also help probably.
Mm-hmm. It seems to me to be a very creative solution that was worth exploring to the problem. In marketing, we talk about segmenting your message to the appropriate market segment, and using something like street plays to a population that has low literacy levels and high communication needs seems to me to be a really potentially original idea worth exploring further. Thank you very much for that.
Thank you so much. Thank you.
Dr. Sakshi, if I may, thank you for your presentation. I think it's, as an educational poster, I think this does a really good job of educating someone who can read, who does have certain beliefs. I think this can help alleviate it to a good extent. My question to you is, if you had to choose any one of these myths, so tackling which of these myths do you see being the most impactful? And why?
Okay, so I would pinpoint the myth, which is TB is caused only by smoking, because I believe that in any disease, not just tuberculosis, prevention is always better than, like the saying goes, prevention is better than cure. So if we talk to people, if we educate people about the prevention, which is basically on the causes, and if people really know the causes, they can actually act to prevent the disease. So the myth, which is TB is caused only by smoking, actually it makes people believe that there might not be any other causes of the disease. So they can just be a bit, I'm not able to catch the right word, but like they can just think that maybe they can be, I'm so sorry. For example, if I don't know that a TB can be caused by someone who's infected and he coughs in front of me and I can inhale the particles, so how am I supposed to, prevent that from happening? So it's important that people know the causes to, actually act on the point of prevention of the disease. I don't know if I made my point.
You did. I mean, it's as you professionally or personally, there could be one or more reasons that could be more important to you, or something you've seen in your practice that, like the patients that you've seen in your practice so far, whether, you've had more people who are coming with lack of knowledge about how it's transmitted, how it's caused. So you did make your point. Thank you.
Thank you.
Dr. Sakshi, this is a very nice presentation and nice poster for display on the site and everything. So I would like to ask you one thing. What is the myth about vaccine? It was not covered in your poster.
Yes, sir. Actually, I did read about it, but I couldn't really find, specific information about that. So I thought, like, instead of putting some half information here, I should just skip it. But I did read about the TB vaccine, which has probably shown to have some benefits, but I'm not sure about how efficient that can be. So I don't think I have an efficient answer here.
Thank you.
So sorry, sir.
So I assume the question answer session with the judges are over.
Yeah, I think we can move to the audience questions, and then Dr. Ilham can join.
Can I would like to add something. I hope I'm audible.
Yes, sir.
First of all, very well done on the poster. It looks good, like relief to eyes. And I would like to add something that we don't say that there are two types of TB, pulmonary and extrapulmonary. For the ease of studying TB, we have categorized them into two categories. One is pulmonary and the other is extrapulmonary. What is extrapulmonary? Anything, any TB affecting any part of body except for pulmonary TB is considered an extrapulmonary TB. And second thing, Dr. Sakshi, like some other judges have also discussed it, I think that this is very, very nicely drafted, and I would like to promote you by suggesting that the work doesn't end here. I think you should really work upon it and come up with some SOPs for medical workers, for students, for researchers, for communities to work towards eliminating the myths. And like we know that TB has been with us from years, decades, centuries, and these myths have been with us from generations. So it is not easy to get over with them overnight. I guess it would be an interesting read to if you can share across some SOPs on how the community, we health workers, researchers, medical students should work upon towards this need.
Sure,
Thank
sir.
you very much. That's it from my side.
Thank you so much, sir.
Thank you, judges. And Dr. Maliha, if you have any questions from the audience, please bring it up.
Hi, Dr. Sakshi. We have a couple of questions for you from the audience.
Yeah.
Your first question is, what medical journals or books did you use for the information that you presented? Your reference shows an internet link. How much reliable or authentic can internet be for facts?
Yes. So basically, my reference is of Aster Hospital, which is a leading name in the healthcare sector. They recently published an article about, I don't know, I don't remember the date exactly, which was a research conducted by a few doctors working in their hospital. So that is where they mentioned all these myths and facts which were very prevalent among the common people, not just in India, but everywhere. I had attended a webinar a few months back, which was given by a public health expert who also spoke about tuberculosis in general, not the myths specifically, but there were a few questions then about spreading knowledge about tuberculosis and how we can act at the community level to prevent and in general manage the disease. So these were my two references. And like I mentioned, it is always important to check your sources and get your facts right before you just believe everything that you see on the internet. So I actually did that. I also spoke to a consultant who I know personally, and that was like a part of the work which went behind making this poster.
Okay, thank you for your answer. You have a second question. Can only spreading knowledge control TB? What other solution is possible in effective control of tuberculosis?
Yeah, so basically, like when you talk about a disease in general, spreading knowledge is, I think, the first and most important thing, because like I said, if you know how it spreads and how it can be like, contracted, it always helps you prevent the disease. But of course, like you can't help really, like even if you take all the measures, you may get the disease eventually. So here, what solution important is telling patients that the treatment of tuberculosis lasts very long. It can last from any time between 3 to 9 months. So it is very commonly seen that the patient compliance is lost after a certain amount of time. which is a very important point to note, because like I said, if it is not treated and handled properly, TB can come back. So I think an effective management by healthcare personnel is very important at this point. So spreading knowledge is just a part of the whole process, I think.
Thank you, Dr. Sakshi. That will be all from the audience.
Thank you so much.
Thank you, Maliha, and thank you, Sakshi. That ends Sakshi's presentation. And I'm now inviting Ms. Asma Khan for her presentation.
Hello, everyone. Am I audible?
Yes, you are audible.
So I will be starting. Good afternoon, everyone. I'm Asma Khan. I'm a third-year medical student from Dow Medical College in Pakistan. And my topic for today is myths about tuberculosis and how to bust them. Now, according to my knowledge, there's a lot of misconception about tuberculosis. And I chose this topic so I could address some of these myths and also to educate people about TB. Now, by clearing these misconceptions, we can encourage or motivate people to know more about tuberculosis, which in turn could lead to increased awareness, more people getting likely to get screened for tuberculosis, and early detection of the disease through treatment. And also this in turn would lead to long term, it will lead to the eradication of tuberculosis. Secondly, there's this misconception or stigma around tuberculosis being a very incurable disease. But if we debunk some of these myths, we can actually help people understand that by early detection and drug compliance, tuberculosis can also be managed and be treated. Now I will move on to the practical application of my idea. We can introduce the education of tuberculosis and the myths relating to them in educational institutes and schools through posters, webinars, attractive signs. Also, we could include these tuberculosis myths in awareness campaigns as a fresh perspective rather than passively talking about TB. The government could also fund research regarding tuberculosis, specifically the public awareness of TB, and help in circulating information regarding tuberculosis myths versus reality, especially in the low socioeconomic communities. As for the hospital care system, the physicians could educate patients about the effectiveness of tuberculosis screening, and also debunk any myths that they might be having. Doctors that are vaccinating patients with BCG vaccine could inform them or the patients of the child that the vaccine, that the purpose of the vaccine is to reduce the severity of tuberculosis and is not necessarily always effective in the prevention of TB. Also, we as individuals can take responsibility and share accurate information about tuberculosis through social media platforms to debunk a lot of the myths. And most importantly, those people that are detected with tuberculosis should clear all misconceptions regarding their diagnosis, treatment, and mode of transmission, so that they are more likely to adhere to the long drug regime that they have to follow for months, and also so that they can prevent transmission to those that they were in close contact with. Thank you very much.
So the judges may ask questions to the presenter now.
Dr. Khan, again, thank you for your presentation. Very enlightening. I would ask you the same question I asked the previous presenter, and that would be, where would you focus your efforts on education if you were appointed the head of tuberculosis control in your country? Where would you focus your education efforts? What aspects of this would you focus on?
Probably the areas that are most uneducated, or those areas that have that are from low socioeconomic backgrounds. Because of the lack of hygiene, they don't have enough money to buy masks and are not aware of all the information regarding tuberculosis that educated people are.
And what vehicles would you use again?
Social media platforms, webinars, posters, even interactive plays, as the previous presenter mentioned, could be used.
Thank you very much.
Thank you.
Thank you, Dr. Asma, for your presentation. I think it's very well organized. I like that it's not very busy. A lot of the information that you're trying to put across is very clearly visible. So good job on that. My question to you is, I do see the numbers that you have at the bottom of the presentation. How does Pakistan fare in terms of TB with the disease burden there? What are the numbers there? What are the top 5 leading causes? Where does TB lie?
I'm not exactly sure, but it's definitely in the top 10.
Okay.
I think 6th, but I'm not entirely sure.
And do you, in your practice or in your experience, do you see any particular stigmas that have been really standing out in the past in your practice?
Yes, definitely, because the treatment of tuberculosis is many months. Oftentimes, the patients, after they take the treatment for 1 month, they're feeling better and they will discontinue the treatment. So that is something that...
Yeah, that's a barrier, I would say. But do you see any particular stigmas associated with TB that that have really stood out in your opinion?
Stigmas would be that either if you're showing symptoms, you have TB, but if you are not showing symptoms, there's no need to get tested, you don't have TB. But everyone should get tested because there is latent tuberculosis.
Okay, thank you.
I would like to congratulate for your nice presentation. As Dr. Varsha mentioned, that it's very organized, not so messy, and clearly visible messages. But I am not sure what do you want to mean by the early detection can significantly decrease the mortality rate. So is this TB is curable or not, according to you?
TB is curable if it is detected early and the patient follows the drug regime prescribed to them. And also if the patient, if suppose there's complications like HIV, if they are free of these diseases, they are more likely to get cured.
Thank you. So do you think that only early detection can significantly decrease the mortality rate? Or it is adherence to the treatment for 1 year will decrease the mortality rate?
Both, because of early detection, there is damage to the lung can be preserved. But if it's detected pretty late, there's a lot of complication that happens to the lung, and it also spreads to other organs of the body. So it is quite difficult to treat.
Thank you. Thank you.
Hi, very well presented, like other judges have commented. Very well done. Though I would like to ask you, like you have mentioned, that only symptomatic TB patients need to be quarantined. I know, like, absolutely correct. But do you want to comment on it? How? Why?
Okay, because latent TB is dormant, and without the symptoms, it is not infectious.
Okay. Thank you. That is absolutely correct. Latent TB infection doesn't show any symptoms, and it doesn't even transmit. If it is not activated, it doesn't transmit from one person to another. And secondly, I don't know the dynamics of your country. I suggested to the previous participant, I would like to suggest you, please like write down some SOPs on how the government systems, how the healthcare workers, how the researchers, students, communities should work on to eliminating the myths related to tuberculosis.
Okay.
Thank you. That's it from my side.
Thank you so much.
Thank you, judges. And Maliha, if we have any questions, audience, and please bring it up.
Hello, Dr. Asma Khan. Audience is asking, audience has one question. How can we use social media for awareness?
We can attend campaigns, attend online webinars, or you go to reliable websites and gather all the information that we know and use social media like Facebook, WhatsApp to share it to as many people that we know, close relatives, friends, so that they can benefit with the authentic information as well.
Thank you. There's another question for you. If not all TB patients can be isolated, when should and at what stage one should isolate them?
If you are showing symptoms, I think you should go to the doctor, get screened, get the test done, the tuberculosis culture, and see if it is positive, then isolate.
Thank you so much. That's all from the audience.
I greatly appreciate the interaction from our audience. Thank you. And thank you, Asma. With that being said, I'm inviting our next participant, Ms. Persia Tanas, for presenting her poster.
Hello, am I audible?
Yes, Persia.
Hello.
Yes, you are audible.
Okay, I'm starting. Good evening and greetings, everyone. I'm Pursia Tanazhok Puna. Currently, I'm a first-year medical student from Shahid M. Mansoor Ali Medical College in Bangladesh. Firstly, I'd like to thank ISCI for giving me this wonderful opportunity to talk about tuberculosis and also learn a whole lot from this process. Tuberculosis is a lurking menace currently second only to AIDS as the leading cause of death all around the world. The topic of my poster is Reasons Why Tuberculosis Has Not Yet Been Eradicated from the World. And my title is Tuberculosis and Why It's Still Not History. The disease is caused by Mycobacterium tuberculosis. An estimated 9.6 million new cases were recorded in 2014, with majority presenting the world's poorest nations, for whom it's difficult to cover the cost associated with management and control programs. In the same year, 1.5 million men, women, and children died out of TB. So we have to acknowledge that TB is a big problem for us. And in order to solve a problem, we need to know why and understand the reasons why it's still existing and not solved in the first place. We need to understand the properties of the pathogen, why it's difficult to diagnose the disease, and why it's becoming resistant. In a nutshell, we need to look deeply into the problem and ask questions why it's still here to stay, and which is exactly why I chose this topic for my best poster presentation today. First, let's talk about the strength of the pathogen. The bacteria grows slowly. The time of its doubling is 18 hours. The disease develops chronically. And the resistance is attributed to one or more chromosomal mutations. Now, the next big challenge is the diagnosis of the disease. Pulmonary TB is easy to diagnose, while the diagnosis of extrapulmonary TB can be time consuming and challenging. Also, the symptoms are quite vague sometimes, and lab investigation samples are also difficult to obtain. 90% of TB infections are asymptomatic, and these are known as latent infections. These latent infections can reactivate and cause symptomatic TB. Now, the next thing that's responsible for its not being eradicated is prolonged treatment procedure, which involves multi-drug therapy. The patients sometimes often can lead to non-adherence to the treatment, and which causes more dropout cases, and these are quite common. Now, these dropout cases then leads to our next cause, that is drug resistance. When dropout cases become common, the bacteria, they become resistant to drugs, and they develop resistance, and it becomes quite difficult for the disease to be cured. Now, the drug resistance can be seen as multi-drug resistant or extensive drug resistant TB. And there are some other factors which are responsible for it being not eradicated. These are prior anti-tuberculosis treatment, then poor socioeconomic condition, illiteracy and stigma, treatment failure, lack of awareness. To address this problem, we need to ensure mass education and ensure more campaigns against tuberculosis. DOT therapy has proven successful in some cases if administered properly. With that, I'd like to conclude my presentation. Thank you all for your valuable hearing, and thanks.
Thank you, Persia. And I'm requesting the judges may ask questions to her now.
Doctor, I think you've presented a good bird's eye view of the scope of the problem that we face with eradicating tuberculosis, of which compliance, of course, is important, highly important. Because without compliance,
I cannot hear your question.
Oh, I think you've done an excellent job of presenting the scope of the causes, the scope of the problem in terms of what stands in the way of TB eradication and control, of which non-compliance is a significantly important part, and I think you should be congratulated for bringing this to the attention. The piece that I'd like to hear from you is, how would you suggest improving compliance in your country? If you were the Director of Public Health of Bangladesh, what measures would you recommend be implemented to improve compliance with TB therapy in your country?
To increase compliance, both government and okay, sir. Thank you, sir.
I think her connection is unstable. Purja, could you repeat your answer?
Hello, am I audible? My network. Sorry, my network. I'm having troubles with my network. Am I audible now?
Yes.
You're audible now.
Okay. You're audible, yeah. Okay, thank you. The question was, how can I increase compliance among the patients in my country? I'd like to answer it in this way. If to increase compliance among patients, both government and non-government organizations should come forward, and education is also necessary. The patients need to be educated. They need to know what are the risk factors of dropout, and also they need to know that about the drug resistance. And funding can also be an important measure, because if we have fund, then these approaches from government and non-government will be more strong, and we can solve the problem that way.
Thank you.
Persia, thank you for your presentation. Again, really great poster. It's very clear. You've covered a lot of important aspects like drug-resistant TB, the challenges with diagnosing TB, which are, I think, very important, like Dr. Sana also mentioned. You spoke about poor quality drugs and in your other factors section. Do you anticipate any other health system challenges in your country's context? And could you think of any ways in sort of avoiding or braving those challenges, so I may say? Did you get my question, or do you want me to clarify?
I got your question. Thank you so much. Besides these factors, other things that I'd like to improve is, I think the core is knowledge. People need to know more. And if they have the proper knowledge, then I think anything is possible to solve this problem.
So my question, to clarify, my question is more pertaining to the health system of your country. So, lack of availability of drugs. Here you've talking about poor quality drugs, but are there any issues with the health system per se that you've encountered, or you think that there's a way of improving your health system in a way to...
Thank you. I think we need more people and more healthcare workers and more health complexes, and people should have access to more information. Then this is one of the problems that I can see, that we need more manpower.
Okay, thank you. That's a great point. Thanks.
Okay.
Dr. Vikas, I think you are on mute.
Oh, sorry.
No problem.
Thank you, doctor, for your nice presentation and nice poster. So I have one question. Everybody is saying that prolonged treatment procedure is a barrier. So don't you think that government should focus on finding new drugs which is not a prolonged treatment? So then compliance to the TB treatment will be increased by that.
Yes, sir. I definitely think new drugs should be discovered, which don't require prolonged treatment, but that requires extensive research and lab works. Also, it requires we need to know more.
And what if I remember correctly, that this WHO started this tuberculosis eradication program in 3 stages. Now it is in the end TB by 2035. So what is the dropout rate when they started initially first, and then what is currently? So is there any difference between dropout rate or no?
Sorry, sir, I don't know the answer to that.
So that current program ends on WHO programs for tuberculosis eradication ends on 2035, that goal of end of TB by 2035. So they have like a stepwise, they started this program, WHO. So what is the dropout rate in between two? Every time everyone is talking about education for, what is the strategy to reduce the dropout rates?
Sir, I have understood your question. WHO has taken an initiative that is DOT therapy, directly observed therapy for treatment of tuberculosis. So researchers say that the patients who have been under DOT therapy, they have cured up to 86 to 90%, and the patients who are under self-administration are cured 61%. So that's a statistic.
No, I am talking about dropout rate, because dropout within like 1 month, 2 months, then it will become multi-drug resistant. So what is the dropout rate when the WHO started in your country, and what is the current dropout rate for TB treatment? Is there any data for that or no?
Sir, the answer to that question is not within my understanding. I don't know the statistics.
Do you know what strategy we have to focus on to reduce the dropout rates?
Sir, we can implement the directly observed treatment therapy more with more diligence. We can also increase the treatment facilities, and the treatment should be decentralized. Then primary education should be developed. More people should know about this.
Thank you, doctor.
Thank you, sir, for it.
Hi. I would like to congratulate you on bringing up this point of tuberculosis diagnosis, which is an issue. And thank you very much, and very well described. Would you like to comment more onto the diagnosis of tuberculosis, pulmonary EPTB? Gold standard test, the test that you run in your country, what are the newer techniques that have been introduced in the world for diagnosis of tuberculosis, the sensitivity and specificity part of the different techniques.
Sir, can you please enunciate the question a little bit more? I didn't quite get it.
First of all, I would like to thank you for bringing out this issue of tuberculosis diagnosis is an issue, is a concern. Do you want to comment more onto the diagnostic therapies and procedure that we have? What do you use in your country? What is the gold standard test for diagnosis of tuberculosis, PTB and EPTB? Also, like what are the newer techniques of diagnosis that have been introduced to the world?
Sir, in our country, we need to increase our health system. We need to improve our health system, and also we need to increase the ratio of patient and doctor. We need more number of doctors.
Thank you for bringing that out. But my question is, what is the tuberculosis diagnostic test that you most commonly use in your country to diagnose tuberculosis?
Okay, sir. So the most commonly used diagnostic method is cough or sputum test. This is used for pulmonary TB.
Okay. And what is the gold standard test for the diagnosis of tuberculosis? And what are the newer diagnostic techniques for the diagnosis of tuberculosis that have been introduced in the world recently?
Sir, maybe acid screening test or gene screening test.
Okay. I would suggest you to go and read about CB-NAT, TrueNAT, and other newer diagnostic techniques. Their sensitivity is as good as 100%. Like, interesting read. You would get to learn a lot from that. That is all from my side. Thank you.
Okay, sir. Thank you, sir.
Thank you, judges. And moving on to Maliha for any audience questions.
Hello, Dr. Persia. There are a couple of questions from the audience for you. The first question is there anything different in approach being done in your country to handle TB?
Something different that's been done in our country to handle TB is, I often see in television, some videographies are being broadcast for raising awareness against TB. So I think that's a unique thing to do.
All right, thanks. Thank you. The second question is, can you please explain the world map that you have used?
Yes, thank you. I have used a world map in my poster to explain the prevalence of TB. Here I have shown with shaded areas the regions where TB is more prevalent, and the lightly shaded areas the prevalence is less. So the prevalence of TB is seen mostly in Central Asia, Africa, and in the former Soviet Union.
Thank you so much. That's all from the audience. Persia.
Thank you so much for your question.
Thank you, Maliha, and thank you, Persia. And now I'm moving on to the next participant, Dr. Siddharth, for presenting his poster.
Everybody can hear me now?
No,
Hello, Dr. Siddharth.
can you please speak clear? Your voice is a bit bad. Can you please off the video and you can speak if you can try?
Is it enough? Any improvement in the quality?
Yes, you may continue. You may start.
I graduated from Government Medical College in Madhya Pradesh, and the topic which I have chosen for the Lysis of TB by ISCI is the myths surrounding around tuberculosis. And the reason why I went with this is because in the current situation which we are in, the pandemic, we can understand that is a very issues when it comes to the various misconceptions and the various types of knowledge which they get from sources which are very unreliable, and it can hurt the process which we are trying to achieve here. Is there an issue?
Your voice is still breaking.
Oh yeah, just 1 second.
Yeah.
I have stopped the timer. I have stopped the timer. Clear the technical glitch and then you can start.
Yeah, I just wanted to confirm, is it better right now?
Yes, it is absolutely better. You're audible.
All right, so I'll just start again. You can start the timer again for me. I'm really sorry for the inconvenience.
Okay.
Yeah, so just as I was saying, tuberculosis is perhaps one of the oldest diseases which we know of. And the reason why I went with the topic of myths surrounding it is because of the current situation which we are in. Given the pandemic, there are so many areas where people have sources of information which can negate the actual trying to focus on. And tuberculosis is also a victim of that particular situation. TB, because of its long duration resistance, has the cultural issues which also propagate the various myths surrounding it. And the ones which I have highlighted in my post over here are some of the ones which were most repeated in the various articles provided by healthcare institutes as well as the publications which I was going through in PubMed. TB is inherited, which again is not true at all, given the fact that it is caused by Mycobacterium tuberculosis, a bacteria. Smoking happens to be a very important cause why people have TB. And again, this is sort of easy to understand why people get this, because smoking happens to worsen the upper lobes of the lung, and TB also affects the upper lobes of the lungs, and both of them have got an insidious onset. So people think that because this person has been smoking for almost 10, 20 years, and that's why he has TB now, which is not true, of course, because TB has a very long dormant state, and therefore when it presents, it could be to anybody who has never smoked also. Then TB also has got a very popular stigma surrounding it, that you can't touch these people or you can't be around them because you also get this infection. And while this is true in certain regions, not the touching part, sorry, I meant being in close contact for long durations can be a very important factor contributing to its spread, and also why our efforts to curb the disease is also at a very big standstill, since countries where TB is dominant, especially India being number one, then the other Southeast Asian countries have got people living very close to each other. There are areas you have almost 6, 7 people living in the same house, and even if one of them has it, the other person can't leave the house and expect someone to move away. So the other two myths apart from this are that only poor people can have it. Again, this is not true, because it is a derivative that close proximity and the lack of availability which people have when it comes to the drugs, as well as in the compliance is poor. So that is why it is seen very much in underdeveloped or developing countries. That is health, and this because of the classic interpretation that, you know, somebody's coughing up blood and they must be having TB, or this person is losing weight and he's coughing all the time, it's not stopping, it's because of TB. No, TB can remain dormant for a long time, and therefore we should not consider it, you know, only in people who have symptomatic presentation. So with that, I conclude my presentation regarding the myths around. I invite the judges for their questions.
Doctor, thank you very much. I think you've highlighted some issues that some of the other presenters have brought up that I think are really important. One question I have as I listen to these presentations is how much do we know about the magnitude of the effect that these myths have on compliance with anti-tuberculous regimens? Do we know how much less likely someone is to comply with their anti-tuberculous regimen if they hold these false notions in their minds?
Well, I guess in such a situation, we will have to do a proper study, because it is not easy to just give out a number or a figure or a percentage in these matters. We will have to definitely create a sample size and then have a regular feedback from these patients, as well as, very importantly, from their relatives and the immediate contacts, because only then can we really come to grasp how much of a problem this situation is. Right now, because of this sheer volume by word of mouth, which doctors, healthcare workers get in their own feedback, that this person has dropped out from our program because they have realized that they're feeling fine in a couple of months' time after taking the medicine and they don't need it anymore. Or they would have heard from somebody else that, you know, no, my so and so said that instead of allopathic, homeopathic medicine is the one way we should go for. So we don't have quantifiable right now sample size which can give us a proper data of how big of an impact this myth and all the issues surrounding it has. But it definitely does, because of the number of years where we have practiced, we have seen our own seniors practice and give us the knowledge as we come to work in rural areas as well, or urban.
My second question may be something that only a professional anthropologist would be able to answer. And that is, where do these misconceptions come from and how do they spread in the population? Do we have understanding about where these ideas come from and how they're transmitted from person to person?
I guess one of the most educated guess one can make is that it is passed down by generation to generation. Given the fact of how old tuberculosis is, we commonly hear it that the elders of that particular community would have said that this used to be in our time also, and we did this, and so this now it has gone away. Or if you don't do this, and then you will not get it. Because in current situation where we are living in, with the ease of access to the internet, it is very difficult to assume that somebody is going to be actually spreading negative understanding of what tuberculosis is through an online platform. It has to be somewhere where the person is not very attached to the online media, but is more in their own sphere where the knowledge is passed down from the community they live in and from the people they are in actual real life close contact with.
Thank you very much, Doctor. Very informative.
Thank you very much, Dr. Larry.
Thank you, Dr. Siddharth. Well, I'm a personal fan of The Office, so this was fun to go through for me. I think it could be a good informative poster for a lot of millennials and Gen Zs who are into that. But a lot of you have kind of touched on arguments and myths that you have covered. Can you talk about some myths pertaining to detection or treatment of TB, the beliefs that people may have about chest X-rays being, the gold standard? That's what a lot of patients believe. Or with respect to treatment, I mean, it's a long duration treatment, and it is a lot of drugs, and people hear about adverse effects that relatives or loved ones have experienced. So how would you alleviate those myths and concerns?
So actually, thank you very much for acknowledging the poster. I was really just going for the Gen Z vibe over there because it felt at the time that online presence would mean that somebody from a new generation would be looking at it. While coming to your question, ma'am, the thing which I believe is the reason why people have such a issue with compliance when it comes to TB, because let's face it, the side effects of isoniazid is, urine is going to come out red or orange. And for a medical professional, that's fine. We can understand that the side effect of the drug. But for somebody who is not in that sphere and they suddenly see that the side effect is causing them to actually start bleeding out, or having that very discolored urine, or some other side effect of our TB medication. So it produces this sort of issue that you're having regarding medication compliance. And secondly, what we can do is that we should sit the patient down and explain them what exactly they're having, how long are they going to be doing this medication for, what are the possible side effects apart from it, and if there is any reason for them to worry, that they should first of all come to the nearest primary healthcare center, alleviate their fears, discuss what exactly is going wrong with them, why they think that they should stop this medication. Because the feedback, the retrieval program which we see in recent times, for example, let me just cite COVID. I am living in a city where we had detection of COVID, and then within every day there will be calls from the government office asking, how are you today? Are you taking any medications? Are you requiring anything? And then this sort of follow back and feedback was so important for the people in general that they were very happy with the situation here. So TB also requires that level of dedication, that level of reach out to the masses,
Yeah, I think pre-treatment counseling in general is something which needs to be focused on, especially given that side effects are seen with TB, but that's, how to navigate it as a patient is something which not a lot of people are aware of. Thank you.
Welcome, ma'am.
Thank you, Dr. Siddharth, for your nice presentation. So first of all, I would like to congratulate on this poster, but some minor advice for you that the color combination is not good on this. So please make sure that next time, please.
Yes, sir, definitely. I understand, sir. Yes.
No, it's okay. This is your first time, so I totally understand your position. So
Thanks.
I would like to ask you one thing. Like as I previously in my introduction, they mentioned that I worked as a program director in Institute of Liver Biliary Science for hepatitis B awareness program, and we have brand ambassador for hepatitis B, Mary Com. So do you think that if we create this type of brand ambassador and they will interact with the public and they will question, answer and everything, and then that will help?
Yes, sir. I completely agree with your just answer that when we have a face to a particular situation, especially something which is so stigmatized. For example, I think Deepika Padukone is the face for depression when it comes to India, and Mary Com is for hepatitis, as you have mentioned. So it definitely helps the command would feel inclined to think that so horrendous can happen to somebody who's so famous and probably has means to a lot of good healthcare. So it will help in making them humanize the person, as well as it will humble them into understanding that we should also follow the suit of what these celebrities or this ambassador is doing, and try to inculcate that as well into our calling for treatment.
Do you think that we have to open some type of like TB, like Institute of Liver Biliary Sciences, focus on only liver and liver and its complications? Some type of, I know there are lots of, in India, we have lots of TB centers. Do you think that if we open only super specialty for TB, right now in India is only for chest and TB is like a specialty program or internal medicine. Do you think that opening in a super specialty program in tuberculosis and their management will help in the management and better diagnosis and management of TB?
Yes, sir. I think it would definitely would be the right step in that direction, because we know that TB, even in the initial phases of diagnosis, is not easy. It's a clinical diagnosis. Then we go towards X-ray to confirm it. Then we go towards sputum, and we know that the growth of TB can take almost 3 to 4 to 6 weeks. So if we have a dedicated center for it, which is studying and trying to make sure that the methodology for detecting it is decreased, the clinical symptoms for identifying is made much more simpler for the peripheral healthcare workers as well as the district hospital workers, and then we can sort of make a pyramid towards guiding the people towards one dedicated center, and then ensuring that these centers are having proper retrieval teams to really make sure that whoever comes to them with positive TB result goes out in 9 months with happy that they have cleared the entire treatment course, and they are going to be reassured of their longevity after the infection.
I have another question. As I asked previously also, what methods or what strategy do you recommend to focus on to reduce the dropout rate?
So the dropout rates which we have seen, for example, we expect the person or the patient to come back within a month's time. And from what I remember from a PubMed study, it was done for 144 people. If we do not have a retrieval team which basically registers the person's mobile number and address, let's say even social media, and are dedicated, paid, even paid to make sure that these people are called and they're reminded that you have an appointment, please come and make sure that you have spoken to your and make sure that you're feeling better and that your drugs are not causing certain side effects, and these are addressed. So when we have this, the dropout rate is decreased significantly. Like from 144 patients, almost 71 can't be traced back. But after retrieval team, it dropped 19. And so that has really helped in making sure that we reach our goal of NTB by 2035. Thank you.
Thank you, Dr. Siddharth.
Thank you, sir.
Okay.
Thank you, judges.
Yes, let's move to the audience questions first. So over to Maliha for the audience questions.
Yes, hello, Dr. Sid. The audience has some questions for you. What references did you use for these myths and busting the myths? Can you hear me? Am I audible?
You're audible.
Is this Dr. not connected still? I think there's...
Yeah, there must be some problem. So let's take a 5-minute break, a quick 5 minutes break, and refresh ourselves. And we can start with the audience questions and Dr. Ilham's question for Dr. Siddharth and rest of the participants also. I hope it's not a very long session. So yeah, please take rest. And
We're doing great. These are good presentations with good questions and answers at the end. So I think the time is well invested.
Yes.
Thank you so much. That's very sweet of you, sir. Okay, so we can wait for 1 more minute and then we can start with audience questions for Dr. Siddharth. Maliha, would you like to take over? Let's do a mic check for Dr. Siddharth first.
Yeah. Are you still connected with us, Dr. Siddharth?
I'll give him a quick call. I think there is some problem.
Can you hear me? Is there any issues?
Yeah, we can hear you now.
Yeah, we can hear you.
All right, sorry.
So we will begin with the audience questions for you.
Sure thing.
Yeah, the first question is asked by Mr. Tanmay. What references did you use for your presentation?
The references which I used were from publications in PubMed. A couple of them were for the Southeast Asian region, and some of them were from the African regions. The rest were from pharmaceutical companies, and they had articles on these as well.
Okay, thank you. The second question is asked by AK. Does only poor socioeconomics scale still associated with poor immunity? Considering the sedentary lifestyle issues with people in all socioeconomic stratas nowadays, should we be changing our approach to the old myths?
The reason why I have cited that the poor socioeconomic regions tend to have a immunity which is not that great is because of the work conditions and the living situation which they are in. The socioeconomic conditions of such areas tend to be surrounded in construction or some other kind of labor force, and therefore the inhalation of various kinds of dust particles and the area where they're working at, they're predisposed to silicosis, pneumoconiosis, and therefore the basic pathology which is associated with TB, you can't make the phagosome to eat the TB bacteria and then keep it contained. And that is why the section which is on the poor side are much more predisposed to developing the symptoms as well as the severe kind of TB. Apart from this, we should change our ways of trying to approach these old myths, obviously, because they are only hindering our own progress in trying to end TB for the rest of the world. The best way for doing this is to have a very dedicated team by both the private as well as the public in making sure that the people are aware of how and what they're supposed to do when it comes to tuberculosis. Thank you.
Thank you so much, Dr. Siddharth. That will be all from the audience.
Thank you.
Thank you, Maliha, for bringing up the questions from the audience, and thank you, Siddharth. Now we are moving on to the next participant, Ms. Zeba. So judges, shall we start with the presentation?
Is the participant ready?
Am I audible?
Yes, you are audible.
Yes. Can I start?
Yes, you can start.
Hello, everyone. I am Zeba from Faculty of Medical Science, Gurgaon, a third-year medical student. I would like to present my e-poster on tuberculosis and some myth surrounding it. Every year, 24th March is recognized as World Tuberculosis Day in order to educate and create awareness about the various facades of the tuberculosis and break the myths surrounding it. There is a considerable lack of awareness among the population about the grave consequences of TB on a person's health. There are also various myths and social stigmas attached to the condition, given which people often delay seeking help. Some of the most common myths surrounding TB are that TB is hereditary. It is not, as genetics have no role to play. in the transmission or development of TB whatsoever. The TB bacteria takes time to develop in a person's body and is caused when one is around people who are already infected with the condition. Another myth can be smoking is the leading cause of TB. The main cause for TB is breathing in affected air. Smokers are generally predisposed to developing respiratory infections and diseases. Hence, they are considered at a risk of developing the infection. Another myth is every individual with TB is infectious. So that's not true. People suffering from pulmonary TB are infective. However, undergoing effective treatment can help reduce the risk of infecting people around the patient. People with infected TB can also use masks to cover their nose, mouth in order to prevent the spread of the bacteria. People also think that they will know if they have TB, which is not true, because with TB, it doesn't manifest in the form of symptoms until the condition has advanced to a severe level. Once you're cured of TB, you will not develop it. Even if one person has been cured of TB, you can still develop the infection a second time, ensuring that you complete your course of treatment when diagnosed with the condition. If someone with TB coughs, you are likely to contract the disease. It's not true. It is passed on through coughing, sneezing, etc. However, it is not spread so easily. One has to be in close proximity with the infected person for a considerable amount of time in order to contract the disease. Now, I would like the judges if they have any questions. Thank you.
Thank you again for your discussion of myths surrounding tuberculosis. I think it's a very nice poster. I really like what you had to say. How would you recommend going about identifying these myths in your patient population? Some of them are more likely to be shared by some people and some by others. In terms of identifying patients who may hold misconceptions, what would you recommend?
First of all, I would like to recommend whenever a patient visits the doctor, they should ask what are the knowledge they know about TB. So that can be a good starting point. Figuring out how much they know and educating them on same. And I think surveys and conducting forums and all of that can also be important to spread general awareness, where people can ask questions if they have any and clear their doubts. So that can be one way to figure out what are the common myths and help them clear those out.
So as a follow-up question, would you do it as a purely qualitative approach, meaning sort of open-ended, you would just ask the patient, what's your understanding of TB? Or would you use a standardized screening tool, since you, like other authors here or other students, have identified common threads? Several of you identified the same issues. Would you recommend using a standardized tool to screen patients for myths, a checklist to see what their beliefs are? Or would you just do it qualitatively? Or would you do both?
Yeah, I think both, because when we talk about quantitative, that will be able to educate the patient, because in most cases they are not that educated and they're not that aware. So I think that can be an open-ended conversation where they're able to talk and be able to ask questions. So in that sense, that will be targeting them, and all those studies can be helpful for us to figure out how to tackle this problem better. So it can work in both sense.
Okay, thank you.
Thank you.
So, Dr. Sami, do you think, is there any gender disparity for that tuberculosis myth? Is there any study published on that? Like male have some myths separately, and then female has some other myths, something like that. Did you get my question?
No, sir. Can you please repeat the question?
Sorry for that. So I just want to, like previously I asked for educated versus uneducated. So is there any difference between male versus female myths? Is there any knowledge, attitude, practice, behavior, something different? Male has some different attitude, or maybe female has some different attitude with their stigma or something, responsibility in the community, or
yeah, in case of female, like when they're screening for infertility and all of that, TB can be one of the reasons and one of the diagnostic factors. And also in HIV patients, TB is also prevalent. So I guess it's somewhat gender based if you think about it like that. And also community based, how open they are talking about it and who is more likely to seek diagnosis. To give a definitive answer, I think I'll have to look into studies that actually give figures, but I can't really give that because, so yeah. That's all I know.
You know, that is very, you answered my question, but what my question is actually what I am looking for, like as everybody knows that our society is male dominant society. So is there any myth differences, or maybe, you know, like education difference in male versus female? So do you think that does really exist or no?
So can you repeat the question? It was not audible.
Sorry for that. So like the strategy is our society is male dominant society, most of the Indian society. So do you think that government is targeting only male people and they are neglecting females, or is there any education difference of male? So what is the characteristic of about this myth in our society for male, and what is the characteristic for female? Like, is there any difference in the myth?
I think in most cases, male are more prone to be smokers, given the lifestyles like in an Indian society. So when we see cases of TB from people who are smokers, you would see more patients are male. So yeah, I would say in the general smoker population that do contract TB, most likely the cases will be of males.
Okay, thank you. Do you know exactly incidence in the female, how many TB rates are?
No, sir, I don't.
Okay, thank you.
I hope.
Thank you for the questions. Dr. Varsha and Dr. Ilham are unavailable, so we can shift to the audience questions.
Right, Maliha, if you have any questions from the audience, you can bring it up.
Yes. Hello, Dr. Zeba. The audience has some questions for you. Mr. Tanmay is asking, what databases have you gone through for collecting the information? Hello, Dr. Zeba, can you hear me?
Yeah.
What would you like me to repeat the question?
Yeah, please.
What databases have you gone through for collecting the information?
Can you please repeat the question? It was not audible.
Yeah, sure. Sorry about that. what databases or what sources or references did you consult for the information of your poster?
Okay, so for references, I've used the Astor Hospital. They have conducted multiple studies and surveys. They have conducted multiple studies and services regarding TB. They also have a special unit for TB. And apart from that, I've also consulted PubMed and various research articles that specifically targeting TB. Yeah.
Okay, thank you. The second question is asked by AK. Is there any other myths which you have personally come across among your circle or surrounding than those mentioned here?
Personally, I've seen we mostly correlate the cases of TB in older generation, like older people are more prone to getting it, but I think like nowadays the younger people are also getting TB. So that's one thing I've noticed.
Okay, thank you so much, Dr. Zeba. That'll be all from the audience.
Thank you.
Thank you, Zeba. So now we are going on to the next participant, Dr. Deepti.
Am I audible?
Yes, you're audible.
This is Deepti. Sorry, hello everyone. This is Deepti. I have recently graduated from NRA Medical College, Andhra Pradesh, India. Firstly, I want to thank ICSL for giving this wonderful opportunity. And now starting with introduction to tuberculosis. Tuberculosis is a communicable disease. It's caused by Mycobacterium tuberculosis. It can affect almost all organs of the body and most primarily lungs and causes pulmonary tuberculosis. Mode of transmission is the droplet infection. And the sources we mostly think was the only source is human case, but the most neglected thing is bovine source too. Of course, the reported cases are very less, but a few cases are reported in my country, India, recently. Like I came across in my undergraduate studies. Actually, this is a concern for us because bovine tuberculosis may sometimes be communicated to man, and also in my country, pasteurized milk usage in homes was very less compared. Unpasteurized milk usage was more in rural areas than pasteurized milk. Also coming to statistics, it is estimated that about 1/3 of current global population is infected asymptomatically with TB, of whom only 5 to 10% will develop clinical disease during their lifetime. This means that we have a lot of asymptomatic patient population outside.
Timing on karna bhul gayi.
It's okay, Ariva. It's okay. Please continue, Deepti. Sorry.
Yeah, definitely. This asymptomatic patient population are the major source for spread of infection. And coming to the endemic countries, TB endemic countries are India, China, Indonesia, Philippines, Pakistan, Bangladesh, and South Africa. Okay, then moving on. Also, we can say TB as a social disease with medical aspects. This social factors include non-medical factors like poor housing, overcrowding, and poor quality of life, undernutrition, lack of awareness, and education. Okay, then coming to the question, reasons why tuberculosis has not been eradicated from the world by now. The reasons I think were inadequate diagnosis and treatment, and spreading HIV infection. The co-infection of HIV and tuberculosis is very common, and this tuberculosis infection is most commonly associated with HIV and diabetes because immunity was decreased in both of these conditions, which is predisposing the patients, making patients more prone to TB. And increasing population, especially in countries like India, where there is a huge number of people, TB can be easily spread. Excuse me. and lack of political will, and also multi-drug resistant TB, lack of drug adherence, excuse me, and socio-economic disparity and poor primary healthcare infrastructure. These are the challenges that are faced to control TB in the world, and also in developing countries like India, China, and Bangladesh, etc. And also one more thing is individuals' community knowledge, attitude, and practices towards tuberculosis is one of the bottlenecks in decreasing disease burden in the world. Even though the government is implementing a lot of projects and many awareness campaigns, the individual's knowledge towards the TB is the main thing which is going to bring down the cases. And there are many myths and facts associated with the TB. And the role of government can be, government has to implement routine courses for the lab personnel and better diagnostic tests at field level, and also pasteurization of the milk before marketing should be made compulsory, and screening and vaccination of livestock for TB, because this can be a source for bovine tuberculosis. And also government came up with three things, the DOT strategy from 1994 to 2006, and then from 2006 to 2015 the Stop TB strategy, and later now NTB strategy. And thank you all, and I'm open to questions.
Doctor, thank you for this excellent poster. I think you've raised a couple of points that no one else really has covered yet, and you are to be congratulated for that. And my question relates to one of those points, and that is the transmission of tuberculosis through unpasteurized milk. Can you comment a little more on how important that method of transmission is at present in your part of the world? How prevalent is unpasteurized milk, and how prevalent is transmission of TB through unpasteurized milk in your part of the world?
Yeah, in India, it's a common practice that even the newborns are fed with unpasteurized milk. Like when mother is not willing to breastfeed, the newborn will be fed unpasteurized milk. And due to poor handling practices and unclean practices, this bovine tuberculosis is really becoming common. Like in my undergraduate studies, I came across many cases. Of course, not many cases. I came across 4 cases in newborns with bovine tuberculosis.
Wow.
Of course, the source was not confirmed. The guess was that because the baby presented with a history of feeding unpasteurized milk since birth, and they presented with tuberculosis. Also, the incidence of tuberculosis in newborns was comparatively less unless the parents were exposed.
Thank you. Very interesting data. Thank you.
Thank you, Doctor.
I would like to
congratulate
for
Dr.
Sorry for the
Vikas
disturbance.
Bansal.
Yeah, sorry. I would like to congratulate Doctor for her nice presentation and very organized, which covers every single aspect of this competition, like what is the myths, why we are not eradicated, and she is successfully delivered the message also. So I would like to ask you one thing, that what strategy do you think, or what barrier do you think that lower compliance of treatment adherence? What is the barrier, and what is the future role that we have to remove those barriers from the treatment adherence and compliance?
Yeah, one of the things is most of the people who are infected well, from the low socioeconomic group. This is not a. This data was obtained by me by doing 3 surveys in my undergraduate studies. Actually, I collected this data to publish a paper. In that, I came to know that most of the tuberculosis infected patients, are from low socioeconomic group, and they were living in the rural areas. Firstly, the low compliance was because of lack of awareness and education, and they were not in the continued follow-up in the hospital because they are living very far away from the well sophisticated hospitals, and because of the side effects especially, they are afraid to take the medicines, and also many members spreading the myths like no, the medicines is going to give you more side effects than actual disease, and all these are creating the patients more fear, and that's leading to low compliance. And I think the thing we can do for this is creating awareness. Of course, government implemented many programs to create awareness, but the thing is they are not ready to accept it. As a healthcare worker, what we can do is whenever we are going for some campaigns or something, or whenever we meet people who are less educated, we can give them valuable information. Of course, how much they take differs, but every time if we repeatedly say something, at least the point get into their mind. Like that's my thing. Whenever I go somewhere, I organized many awareness camps, like not only related to tuberculosis, but especially menstrual hygiene, cervical cancer, breastfeeding. What my feeling is, at least some points get into their mind that's going to make a lot of difference in their life. So education, awareness, and repeated campaigns and repeated awareness programs are important to bring a change, especially in country like mine, in India, which is densely populated, and also TB cases are very high here. So awareness and education is very important.
Thank you. As your poster, we saw there is a 3 strategy: the DOTS strategy, Stop TB strategy, and now End TB strategy, which is goal for 2035 for eradicate the TB by 2035. So do we have any data, as I asked previously also, for dropout rates and to compare dropout rates? Did you look for the publication around that or no? What is the treatment adherence rate or dropout rate in between these 3, or maybe government document they listed somewhere?
No, I haven't gone through the data regarding this, but I'll make sure that I'll go through the data and know about it.
Thank you.
Thank you, Doctor.
Thank you, judges. I assume we can move on to the audience questions. And Dr. Maliha, if you can bring up the audience questions.
Yes. Hello, Dr. Deepti. Am I audible?
Yeah.
The audience is asking, does any comorbid diseases affect its prevalence and myths?
Yeah, HIV and diabetes is going to affect the number of cases of TB because these 2 diseases lower our immune system, and low immunity is going to predispose us to tuberculosis. Did I make a point? Is that what you asked?
Yeah, thank you. And the second question is asked by AK. What can be done to keep patients adhered or compliant to treatment for the prolonged duration, other than campaigns? What else can make our patients more compliant?
Can you please repeat the question? I have unstable internet.
Yeah, they're asking what can be done to keep the patients more compliant to the treatment for a prolonged duration.
Okay, yeah. As someone discussed, one of the participants in this, retrieval teams are really very important. Yeah, I came across this data. Retrieval teams decrease the non-compliance very much. And also patient awareness is going to do this. And also the prior information should be given by doctors. Like when a doctor is prescribing the medicines, the doctor should also say the side effects like orange colored urine, everything, so that the patient if the patient know this information already, he'll be okay, that okay, this is normal and may not be afraid. That's one thing. And also proper guidance and asking the patient to come for follow-ups frequently. And also through the governmental programs, the DOTS really helps for that, for good good compliance of the patient. Yeah, that's all. Thank you.
Thank you, Dr. Deepti. That'll be all.
Thank you, Malika.
Thank you, audience, for your wonderful participation. And thank you, Malliha. Thank you, Deepti. We are moving on to the next participant, Ms. Urbita.
Am I audible?
Yes, Urbita, you're audible.
Can I start?
Yep, you can start.
Yeah.
Okay. A total of 1.5 million people died from tuberculosis in 2022. Worldwide, tuberculosis is the 13th leading cause of death and second leading infectious killer after COVID-19. Greetings and good evening, everyone. My nature and my name both go hand in hand. That's mesmerizing. Yes, my name is Urbita Mujumdar and I am a learner and also a first-year MBBS student at Rangamati Medical College from the city of Lakes, Rangamati, Bangladesh. Thank you, ISCI, for arranging such a program on tuberculosis in the modern era, which is a burning issue. Also, thank you for giving me the platform on such an international event and giving me a chance to learn from such enlightened souls. As per my presentation, you already may have seen that my topic is community knowledge, attitude, and practice towards tuberculosis. We all know that tuberculosis, an infectious bacterial disease caused by Mycobacterium tuberculosis, continues to be a major public health problem. Though lung is the most commonest site for tuberculosis infection, the organism can infect any organ of the body. According to the pie chart in my presentation, you all can see that knowledge among the general population about tuberculosis is not adequate. An estimated 3.9% of new tuberculosis cases and 21% of previously treated cases had monodrug resistance and multidrug resistance. Prevention of a disease comes from having proper knowledge about it and showing positive attitude to control it. Community participation plays an important role along with intersectorial approach. So I wanted to talk about community knowledge, attitude, and practice towards tuberculosis. Why isn't TB getting eradicated? As I have stated earlier, in the community there is adequate knowledge, attitude, and practice regarding tuberculosis. As the percentage is low, people with tuberculosis often drop out from the drug regime. As there are a lot of dropout cases, there is a rise in monodrug resistance, multidrug resistance, and extensive drug resistance. Due to this rise, there is also economical burden on the people, which eventually affects their perception regarding tuberculosis. In the end, this becomes a vicious cycle. If the knowledge, attitude, and practice gets intensified, then maybe the tuberculosis will get eradicated. So what implications or measures should be taken? First of all, there should be mass education regarding tuberculosis. Secondly, in the mass media, there should be informative content that should be displayed to create the awareness among general people. Thirdly, awareness should be included in the education system regarding tuberculosis. Finally, new policies should be implemented regarding tuberculosis. According to WHO, there is a concept called DOTS, but the outcome of DOTS is not much up to the mark. The DOTS should be monitored properly to intensify its activity. After such implications, there would be less drug resistance, more knowledge, attitude, and practice, and less economic burden on people. At the end of the day, we may prevent another possible epidemic and save millions. Thank you for your valuable time and kind consideration. If you have any questions, feel free to ask. Thank you all.
Doctor, thank you for this excellent presentation, very clear poster, and a good talk. In terms of the beliefs, I think it's interesting that you mentioned keeping it secret when a family member gets TB. How prevalent of a problem do you think that is in your community? And how, this is challenging because these are people that might not be easily detected. how would you go about detecting people who hold this problem, and how would you advise reaching out to them?
Sir, keeping it secret when any family member gets tuberculosis, it's sorry, sir. It is a common attitude that when a family members get affected on TB, it's very prevalent to keep secreted.
Do you think it impairs the detection of tuberculosis in your community? Have you found that this creates a reservoir of people who are infected but refuse to get looked at or engaged by the system?
So by creating awareness and educating people extensively.
Okay. All right. Thank you.
Thank you, sir.
Thank you, Dr. Urbita, for your nice presentation. It is well organized. But when I saw the references, there is one reference you mentioned about MedRxV. So that is tuberculosis. So this was not on the peer reviewed yet, that article, or it is still preprint? MedRxV.
Yes, it's affect the community prevalence too.
No, this is peer reviewed or not? My question is this.
Sir,
The third reference you used for knowledge, attitude, practice, and determinants of them towards tuberculosis in Bangladesh, cross-sectional study. It was not peer reviewed yet, right?
Yes, sir, not in peer review.
So as I see from your pie chart, there is like 50% is knowledge, attitudes, and practice is there. So what other things you think that you should include in this presentation?
Sir, I should include some drug resistance and
Drug resistance, yes.
And
what about the like you mentioned about adequate knowledge is also 50% and poor knowledge is 50%. So this is based on which article you are talking about, from the second one or third one?
Sir, the third one.
Third one, okay. So does they measure about what adequate knowledge they have 50%? Like what criterias? Like knowledge about diagnosis, knowledge about bacteria, as previously we saw from other participants' presentation, there is a myth about knowledge for that is genetic. So what adequate knowledge they have it in this article? You got my point or no?
Sorry, sir, I didn't get you.
So as previously we saw in previous participant, they provided the knowledge gaps, like they have myth about that page. This is coming from smoking. This is not. This is a genetic. So as I can interpret your first pie chart, that is they have like similar 50% knowledge, adequate knowledge, and poor knowledge. So this knowledge is regarding what? Is this bacteria, or what is the denominator for this adequate knowledge in the article if you read this one?
Sir, first of all, the pie chart is not 50-50. Adequate knowledge is 47.8% and poor knowledge is 52.2%.
Yeah, that I got your point. That is 47, but it is around 50%. So what denominator they use for this pie chart?
Sir, validated questionnaire for measuring knowledge.
What denominator? I did not get you. Sorry for that.
Validated questionnaire.
That's what question they ask for, like what type of questions they ask for. That's my question, is what type of knowledge question they are asked in their questionnaire.
Sir, about bacterial infection.
Okay, so according to this pie chart, means that everybody knows in that 47% population know that this TB is from bacteria. What?
It's not so, not really. There is also some question that transmission of TB, availability of TB treatment, about organism.
Okay. So if they already have around 50% knowledge, so why that they did not adherence to the TB treatment and everything? What did the authors mention about something or no?
Sorry, sir, I didn't find anything like that.
Okay. Thank you. So this is from the third article you are talking about, preprint one?
Yes, sir.
Okay. Okay, I will read that. Okay, thank you.
Thank you, sir.
Thank you, judges. And Maliha, you can share the audience questions now.
Yes. Hello, Dr. Urbita. Audience would like to ask you, to what extent can volunteerism help to increase the knowledge, attitude, and practice among general population?
Okay, in developing and underdeveloped country, it would help economically to reduce tuberculosis cases, and it would reduce dropout rates.
All right. Second question is, how do we improve the attitude part of our general population?
Sorry, I didn't get you.
How do we improve the attitude part of our general population?
By sorry, by some awareness program via social media, education program, and availability of tuberculosis treatment, and so on. I can improve attitude towards tuberculosis.
Thank you so much. That will be all from the questions, Dr.
Thank you. And now we are moving on to our next participant, Ms. Konero Divishki.
Am I audible? Hello.
Yes, you are audible. We can hear you.
Thank you. Warm greetings to respected dignitaries and the attendees of the meeting. Myself, Divyasri, studying 4th year MBBS from Andhra Pradesh, India, and I'm going to present about myths of tuberculosis and how to bust them. Even though tuberculosis is known from a long period of time to the humans, there are many myths surrounding about it. Like tuberculosis is hereditary, it is non-curable, it affects only the lungs, affects only the lower socioeconomic status, and tuberculosis occurs due to smoking, and it is and if the one is symptom-free, they are not suffering from tuberculosis. Contrary to that, genetics has no role to play with tuberculosis, and it affects other organ also. And tuberculosis can affect other groups, not only the lower socioeconomic status groups. And also, if one is not having symptoms, they are not completely free of tuberculosis. Like latent tuberculosis may be present. And the smoking is not the cause; it is one of the major risk factors for tuberculosis. And another myth being, once they are vaccinated or cured of tuberculosis, they will never contact TB again. Again, this is another one of the myth. And sharing of utensils, food, and handshaking spread tuberculosis. This is one of the myth, and actually it is spread by airborne particles. All the tuberculosis infected persons are not infectious. Only the pulmonary tuberculosis persons are infective. And healthy individuals have strong immunity in order to tackle the infection. So why do we actually need to bust these myths? What use we'll get? Spreading awareness regarding the cause and modes of transmission help the individuals to take effective preventive measures like good ventilation, proper ventilation, and good proper hygiene, etc. And this helps in turn reduces the incidence of the disease. To help discriminate against the people who are suffering from tuberculosis and also decrease the social stigma which is associated with the disease. People will not see them as untouchables. Knowing that latent tuberculosis exists, it helps in early detection of tuberculosis and decreases the disease burden and the transmission. Acknowledging that TB is curable improves the rate. Explaining patients and family members about the treatment plan, it helps in treatment success rate. And how can we actually bust this myth? What can we do practically? Making posters and pictograms about the tuberculosis at important sites like hospitals, primary healthcare centers, vaccination sites, and public places like bus terminals, etc. Including tuberculosis curriculum in the study of all the students. Explaining the treatment, the plan of treatment, adverse effects associated with the treatment, and the involvement of family members is also important at the time of diagnosis. Involvement of public and involvement of public is also important. Educating about cough fatigue to the patient also helps in reducing the disease burden. Tuberculosis awareness events can be conducted in the workplaces and also in different various sectors. Multi-sectoral involvement like news reporters can be involved, and also the political member parties can be involved. And also spreading awareness about tuberculosis in multimedia, like using folk songs and using newspapers and news in general in the television, etc. And questioning the knowledge about tuberculosis among the public and correcting them is also very much important. Thank you.
Doctor, thank you for this excellent presentation. I have a couple of thoughts that I'd like your input on. The first is you also make reference to reservoirs of TB that may be a little harder to reach, that the healthcare system may have a little harder time reaching. One is, of course, stigmatized people whose families or who themselves are either in denial or actively try to hide the patient from being identified by the system. And the other one is, of course, latent TB, which may have its own set of considerations in terms of dealing with myths and identifying patients. So I'd like you to comment on that a little bit. And the second thing is I'd like you to tell me a little bit about is there a knowledge base, a research base that addresses the effectiveness of the different myth-busting methods that you propose? Do we know if some of these are more effective than others, and if so, what are they?
Commenting about the latent tuberculosis, yes, it is difficult to identify individuals who are suffering from latent tuberculosis, but we can reach out to the important high-risk individuals or close contacts of tuberculosis who are likely to have chance of latent tuberculosis, and we can conduct diagnostic studies for them in order to diagnose them so that they will not turn into acute tuberculosis. This in turn reduces their disease burden. And involving family members in case of during the treatment plan, it helps in more treatment compliance and adherence to the treatment, and it gives emotional support to the patient during these times.
And then regarding effective methods of reaching people, what do we know about the effectiveness of the different techniques that you propose? Do data even exist? Do we know?
No, sir. I just propose some of the ideas which I'm thinking about how we can bust the myths.
Okay, so it sounds like an area for future research.
Yes, sir.
Good.
We can research about which is having a higher success rate, and we can implement it on a wider basis.
Thank you.
And
that's insightful.
Thank you, sir.
I have one question. Is there any, as I see on PubMed, there is lots of studies done for stigma, TB stigma, what is the currently status and what is the strategy? So do you think there is any successful strategy for that, removing the stigma, social stigma, and what type of social stigma right now in India?
In India, we consider people, some people consider that if they are suffering from TB, all are infectious, but most of the, if the patient is taking the treatment, then he will become non-infectious mostly from second week. So we can reduce the discrimination against people, and also there is some myths like even one contact we can get TB. That is another myth which is present, and utensil sharing, food sharing is another one which may be prevalent.
Does there any stigma regarding failed marriage prospectus or something like that? A male and female disparity regarding that, or maybe females has some other fear factor which is not listed in this slide?
Males are more affected when compared to females because of smoking risk and increased exposure to various areas. And females, there is a myth that they may become infertile following the infection from TB.
Thank you.
Thank you, sir.
Thank you, judges. And Maliha, you can bring up the questions from the audience.
Hi, Koneru. I have a question for you. It's true that TB treatment is not expensive. How are we trying to manage the mental stress or loss of wages or employment, etc.?
Yeah, TB causes a very high socioeconomic burden because of the loss of workers. But as I have already mentioned, if the patient is taking effective treatment plan without any leaves, if he is sticking to the treatment plan, from second week onwards, he will become non-infectious. Then he can continue with his work if he is feeling all right and without any adverse effects.
Thank you, Koneru. That will be all.
Thank you.
Thank you, Koneru. Thank you, Maliha. And now we are moving on to the last participant for our presentation today, Dr. Hanil Upadhyay.
Hi, am I audible?
Yes, Hanil.
Good evening. My name is Dr. Hanil Upadhyay, and I'm a medical officer in one of the tribal forest districts of Gujarat. And my topic for presentation is reasons why tuberculosis is not eradicated from the world by now. So I have 6 to 7 reasons to believe from my experience of working in the grassroots levels and with the government sector that why TB has not been eradicated. And I think we can extrapolate the reasons on a national or a global level. So one of the reasons right now is the growing antibiotic resistance. Like we are already seeing resistance to isoniazid and rifampicin in our areas, and the government has now started testing every tuberculosis patients for rifampicin resistance, whether the tuberculous bacilli are sensitive or not to rifampicin. Second is that due to long treatment duration, there is growing antibiotic resistance. That could be one of the reasons. Second is socio-economic disparities. I do not believe that only the lower socio-economic class people are more prone to tuberculosis. Maybe because of the poor nutrition practices or high rates of smoking and other addictions, they can get easily infected by tuberculosis. But even tuberculosis is even seen in the higher socioeconomic groups, even with all those hygiene practices. So that is one of the reasons. Third is the research to develop a vaccine that prevents the new cases of tuberculosis, like the BCG vaccine that we have right now. It usually decreases the severity of extrapulmonary tuberculosis, but it does not prevent pulmonary tuberculosis on a 100% scale. So we need more research into developing a vaccine that would prevent and eradicate the disease. Then is one of the reason is lack of drug adherence. In India, we have the TB regimen for 6 months. That is 2 months of intensive phase and 4 months of the continuous phase. So a total of 6 months for pulmonary tuberculosis and a total of 12 to 18 months for extrapulmonary tuberculosis. Now that is a long term treatment. So many patients have loss of follow-up. Many patients are prone to loss in the medication routine, and it's difficult to reach patient in hard to reach areas such as the hilly terrains or those living in the forest areas. So it's difficult for the healthcare staff to look out for all the patients, and there are like pockets in which there is a high incidence of TB. So we need to focus on that also. The second reason is a lack of political drive. Political will plays an important role in eradication or elimination of any disease. Once we have a national level program, then there is a structured and an organized way of treating and preventing a disease. But without a political drive, it is very difficult to highlight the issue of any disease. Another could be negligence of people because of low literacy rates, or because people are not well aware of the disease. There are many myths, as the other participants talked about, and there could be many questions which the patients would have regarding the disease, which are not cleared by us. So I think those are the reasons why TB is not eradicated. Thank you. I am open to question from the judges.
Doctor, thank you for your presentation. I think it's really valuable to hear from frontline physicians such as yourself, because I think your insights really can be valuable to those who must implement policy and view this from the top-down point of view. So again, thank you for your work, and thank you for sharing your insights. The question I have for you as a frontline worker is that in any complex system or in any large effort, such as the eradication of TB effort, there are bound to be disconnects between what people are thinking at the higher level and what frontline workers such as yourself are experiencing. What insights can you offer us in terms of what these disconnects are, and how to mitigate them, how to make them less impactful on the population that you serve?
Yes, sir, you are absolutely correct. There are various levels of disparities we see that on a national level or on a state level, the tuberculosis program would be shown in a certain way, and while it reaches to the grassroots levels, to the workers, people might think that we are not giving it very much importance, or there might be other new programs or new strategies coming up. So there is a level of what I can say is uncertainty that people have with the government sector, that we are not able to provide very effective treatment and preventive strategies to them. So yes, there are trust issues sometimes. What we can do is we could be having effective counseling methods. We have to bridge the gap between the healthcare or the frontline workers and the community by using various stakeholders like religious leaders or educators, and the government in India has a really good program of the social workers, that are the ASHA workers, the social health activists that are working in every village. So people would not trust a doctor, an outside doctor like me, but would trust a village person whom I have educated regarding the disease. So I think we need to empower those health activists and volunteers in eradicating a disease. So they have better communication with the village people than myself. I might have the knowledge, but they have the experience in dealing with those villagers.
That is a very insightful observation, Doctor, and I really have to thank you for that. My question would be, if you could talk to the head of the World Health Organization, what advice would you give? And I think this point that you just raised is truly excellent. Talk to people at their own level, one-on-one, find ways to relate to them that perhaps haven't been thought of before. Thank you very much for that insight. I think it's a really important one.
Thank you, sir.
Hi, is it Dr. Hanil? Is that how you pronounce your name?
Yes, ma'am.
Okay. Honestly, I think you did a very good job capturing the essence of the issues that we have with TB right now. One, I guess, suggestion that I would give you is that the way you presented, that kind of is not, your poster doesn't really talk about that much. So if you are ever making a research poster, an academic poster, or an informative poster, just kind of having more information about what you're talking about, because you had a lot of great points. So just having that on the poster would be really helpful and very informative for the audience. My question to you is, you speak about lack of political drive. As a frontline physician, what is the area of policy change that you would recommend or that you think would be really impactful?
I would suggest empowering the grassroots level workers because they have the real connection with the people in the community. Also improving, like as I said, the stakeholders, they have real influence in the community, like decision-making power. Usually people follow them. Also, like on a national level, we have a lot of actors, actresses. They can influence large groups of people. And on a national level, I think that when a national leader is really interested and dedicated to working in a program, I think that can bring real change because he has a lot of people under him. He has like the whole country under him. So I think political drive is really important for any program to succeed, be it human resources or funding. Everything can be managed, I think, through political drive.
So just to get this straight, so do you think that the impact would be much greater if it's on a local level, or is it more on a national level for policy change?
I think it needs a balanced approach. Like we need a local level empowerment, but we also need a national political drive. Like we had like on a world level for polio. So we need that for tuberculosis right now, like we have for COVID-19. So I think the next should be tuberculosis.
Okay, thanks so much.
Thank you.
Hanil, I would like to congratulate for making a nice presentation. As Dr. Varsha mentioned about that, this is good way of presentation, but still missing some information which should be in the poster. It should be there, that like little bit information, so you can work on that one. And that my question was for political drive. So as previously one of our previous participants showed that in 1994 they started with the tuberculosis program. So do you think in 1994 to till 2022, almost 20 years, we don't have political drive for this? And we did not spend money for RNTCP program? I hope you know
yes,
about RNTCP. Yeah.
Yes, sir. We have spent a lot of money, and even I can say like right now I'm working at a field level, so lots of money are being spent. But still there are a lot of issues regarding drug availability, testing availability at the field level. So money is being spent, but I think we need to do more.
So in what area we have to focus on? So that you are talking about testing kit and drug unavailability, that central government is providing lots of fund to the state government and from their RNTCP program. So there is a something gap. What I understand, that central government is creating the planning for 5 years or 10 years, and they are giving fund to the state government. So on which level do you think there is a, like miscommunication and mismanagement of this program, where
Yes,
we
sir.
should focus on those type of things?
Yes, sir. Like right now we have the NTB strategy for 2025. And the central government, even the state government are doing a lot to achieve in that. But I think right now we have constraints in human resources. Like there are not a lot of doctors or frontline workers for any program, like because we are in a government sector, there are multiple national programs running simultaneously, be it COVID vaccination or tuberculosis or leprosy. So while managing a lot of programs, there has been a dilution in the quality which we are providing to patients. So I think what we need is more people, more volunteers, more organizations to participate in ending this disease, in helping the government achieve its goal of ending TB by 2025.
So how do you justify this lack of political drive, as you mentioned, as a reason why TB is not eradicated? So where is the gaps in the central governments or local government or state governments has, so how do you
no, sir,
describe this?
I didn't mean that there is a lack of political drive, but like not in India, but it could be one of the reasons why a disease would or a disease or a program would not succeed. That was my point of keeping it in the presentation. In India, we have a full political drive for ending tuberculosis.
Thank you.
Thank you, sir.
Thank you, judges. And Maliha, you can share the audience questions with us.
Hello, Hanil. Sorry, but there are no audience questions for you.
Okay, thank you.
It's almost 12 a.m. In this part of the world, so it's okay if the audience has gone to sleep. Yeah, Anjali, over to you.
Yeah. So now Dr. Larry wishes to share his thoughts with us. So we are so excited to hear from you.
Well, I'd first like to ask my fellow judges if they have any summary comments from the session today.
I can start. I think it's been a great effort from all of the participants. There's a lot of new ideas, a lot of things that are issues of prime importance that need to be discussed in terms of TB, which you've kind of brought to the spotlight. I would, however, recommend further research. Try to avoid, news websites and grey literature, and try to look at research that's been published by authors from your country, or things that have been published in international journals. If you're citing references, always cite references if you're doing an academic or a research poster. But overall, I think it's a good effort by a lot of the participants.
Thank you. Doctor, do you have other comments for the participants?
Thank you, Dr. Sona, regarding giving me opportunity to speak about this. As Dr. Varsha mentioned about that, I would also recommend that please go through the PubMed and reliable sources to put the information on, as there is a gender disparity is there, gender stigma is there, so no participant is talk about that stigma or participant. There is a difference characteristic also available on the PubMed, and there is a strategy also available where that they reduce the adherence for treatment adherence. It is published from the Brazil, so please read those articles. But overall, that today event is very good, much more informative and much more interactive. Thank you all. Kudos to all of you. Thank you.
Yeah, I would like to share my approval that my fellow judges have expressed at your efforts, at your interest, at your eloquence, and at your commitment to dealing with this problem. I think I share with my fellow judges the sense that there is no such thing as too much scholarship, that the more rigorous you can be and the more you can learn the formalities of research discussions and educational sessions in the truly developed scientific context, the more effective you will be at this. And so things like using primary literature, avoiding plagiarism at all costs, or, if you're going to cite someone and make it clear where your sources came from. Using high quality sources and applying good degrees of skepticism are all important traits to develop, and I would encourage you, as my fellow judges have, to continue doing so. Having said that, as with all good scientific and educational sessions, good sessions tend to raise as many questions as they answer. And I've seen a few that come out from this particular session that I think are worthy of further attention and further thought. So if I may, I'm going to share a few questions that came to my mind as I listened to your presentations. The first one is, a lot of you covered the knowledge gaps. And so the question that I would have is, what predicts a knowledge gap in the populations you are serving? Is it socioeconomic status? Is it gender? Is it the effect of leadership in the community? What are the predictors? Because knowing what those predictors of knowledge gaps may be may help us address them. The second one is, how do these, at a more granular level, how do these gaps in knowledge affect compliance and cure rates in tuberculosis? In general, in medicine, it is true that the more a patient knows, the more likely, we believe that it's more likely they're going to comply with medication, but time is limited. So what knowledge gaps do we focus on? What are the ones that really screw up somebody's compliance with TB? What are the ones that really correlate with poor outcomes? And that's where I would start in my effort to focus on the effect of improving knowledge gaps in terms of TB treatment. The third thing is, what do we know about interventions that can improve the knowledge gap? Are there things that can improve the knowledge gap? Are there things out there that can improve compliance? What interventions in terms of knowledge gap actually reduce morbidity and mortality? So I think more research is warranted into this particular area. The other part of this is, some of you pointed out that what works in terms of efficacy in a research study may not be the same thing that predicts efficiency in the field. So what do we actually know about the application of our knowledge about tuberculosis in poor and underserved areas? Some of you have pointed out how difficult this can be, and I think it is an area worthy of further investigation. And that includes things like diagnostic methods. The diagnostic methods that may have the most sensitivity in a tertiary care center in New York City might not be practical in the field in a rural part of India. And so a better understanding of the practicality, in addition to the sensitivity of different issues of TB control, including diagnostics, is certainly an endeavor that I think is worth it. We might be surprised if we actually looked at what's happening out there. A better anthropological understanding about the origin of misconceptions and how they spread. Several of you cited social media, but at the same time, I'm not sure that some of your rural patients are really all that involved in Facebook. I mean, I think Facebook would hope so, but we don't know. So a better anthropological understanding of the origin and spread of myths, I think, would be a fruitful level of endeavor. And I'm sure there's some enterprising anthropology graduate student who would be more than happy to cooperate in this kind of effort. How do we screen for these misconceptions? Some of you mentioned that there's social stigma attached with that. This would tend to remove people from the system. If there's a stigma, then it stands to reason that these people might not want to be identified. So how do we identify the people who are hiding out because of social stigmas and misconceptions? If we're ever going to eradicate this disease, we have to identify not just the obvious cases, but the cases that don't want to be found so easily because of social stigma. There is, of course, with all of this, these memes and myths may evolve over time. Some of them are likely timeless and date back centuries, but some of them are likely new. And so ongoing surveillance for what the prevalence of different myths and what the effects of these myths are seems to be a worthy endeavor. And then, of course, there are special populations of TB patients, and you've mentioned a couple of them. One is the bovine tuberculosis patients, which may be a very different kettle of fish or a very different population in terms of their knowledge gaps and the needs and the ways to address it than, say, an adult smoker who acquired pulmonary TB through contacts in the community. What methods do we have other than what new creative methods could be applied to the problem? I think the idea of street plays is really original. I mean, it's a really original way of approaching this problem, and I think that's definitely worthy of further study and further attention. Dealing with social stigma. Some of you mentioned contacting non-traditional healthcare, non-traditional providers of information in terms of healthcare, such as religious figures, as a way of dealing with knowledge gaps and perhaps a social stigma as well. Getting religious leaders involved in reducing social stigma could actually prove to be a very fruitful way of going about this. Certainly the polio eradication campaign, I would think would agree with that statement. How to improve coordination between top level people and frontline workers. I mean, this is a problem of organizations from time immemorial. The way things look at 2 p.m. and in the afternoon in Geneva might not be the way things look at 2 a.m. in rural India. And so improving that communication flow and coordination between high-level policymakers and frontline workers is an eternal problem, and one that I think input from the frontline workers makes, I think in that sense, input from frontline workers is essential. The flow of communication really should be bidirectional to achieve maximum, one would hope, to achieve maximum efficiency. And then the last thing, and I would remind my fellow judges of this, is sometimes the most naive student and the most removed frontline worker can ask questions that the greatest sage in an academic center can't answer. And so my last exhortation to you is keep asking those questions, because it doesn't matter what level you're at or where you are, your questions may actually be far more difficult and far more insightful than the most tenured professor can answer. Keep asking the questions. Don't take it for granted. Keep asking them, because that's where new hypotheses and new ideas come from. People asking questions. So keep that part up, never give up on it, and never get to an age where you think that all the questions have been answered, because they haven't. And again, thank you everyone for a very informative, educational, and quite frankly, inspiring session. I really enjoyed your presentations. I hope that you don't take any of the feedback as critical of you personally. Feedback is how we get better. No one's perfect, and hearing from others is really important. You've done a great job. You give me great hope for the future of our profession, and I hope to see you in the literature and in scientific conferences in the future.
Thank you, Dr. Larry. That was so insightful. Now I would like to invite Purva for delivering a vote of thanks.
Thank you, Anjali. Well, I can tell that every person in this video call is going to work towards eradicating tuberculosis, and it ended with such an inspiring note, and thank you so much for that. I would like to thank all our respected judges for sharing your valuable time and knowledge with all of us. Dr. Larry Sona, Dr. Varsha Bhashekarla, Dr. Vikas Bansal, Dr. Ilham Zaidi. I have been sending you messages and emails, and you have been very, very patient with me. So thank you so much. Thank you. I would also like to extend my thanks to our collaborating partners, that is the Global Association of Indian Medical Students, the Global Consortium of Medical Education and Research, the International Federation of Medical Students Association Bangladesh, and the Nepal National Students Bioethics Wing. I would especially like to thank Dr. Tarun Subari, the National President of James, who has helped us a lot with technical support. This was the first of its kind event for ISCI, and we have had a lot of help and support from all of you. I would like to thank the organizers of this event, Dr. Ariba Beg, Dr. Suganya Karikalan, Dr. Anjali Raj Arun, Dr. Maliha Ansari, Mr. Deepak Bethinidhi, and Dr. Ananya Dubey. Thank you so much, guys. Thank you for the late night phone calls and the early morning ones. Some of us are in the US, some of us are in India, so a lot of fun in time collaboration. In the end, I would like to thank the pillars of this competition, the participants, the audience. Thank you so much for making this event a success. Thank you, guys. Have a good day, and yeah, bye-bye. Take care. And let's cause like crisis of this TB Lysis. Yeah. Bye, guys. Thank you. Thank you so much.
Thank you so much, everyone.
So we can end our meeting here, and I would get back to you with the results on 24th of March. The top 5 participants will be announcing on 24th of March. Thank you.
Thank you. Thank you, judges.
Thank you, everyone, for staying up so late.
I would request the judges and the organizers to stay back for a minute. Dr. Larry wishes to have a word with us. Dr. Vikas seems to have left, but I will convey Dr. Larry's message to him.